So welcome to everybody. More and more people are joining this first event from the PDPAL project. We are really happy to start with a great webinar featuring two, I would say, outstanding personalities from the world of palliative care and neuropalliative care, because today the accent would be and the focus would be how what are the principle and concept of palliative care and their relationship with neurological disorders. I will give a brief introduction about our project, but first of all, I would like to say that after the intervention of Professor David Oliver and Dr. Simone Veronese, it will be possible to have a short discussion with a Q&A session. So all of you are invited to use the Q&A functionalities by clicking on the button on the dashboard of Zoom, and we will read your question for our speakers. So I think now we can start. So again, welcome to the people who have joined in the last minute. This is the first event of a series of webinars that will take place in the next month, and they are organized by the PDPAL project consortium. PDPAL project, it's a project about palliative care for Parkinson's disease, and it's funded by the Horizon 2020 program of the European Union. And we are really happy to start this series of events to communicate and spread the voice about the mission of this project. Today, we will have two very important personalities talking about palliative care principle and concept, who are Simone Veronese and David Oliver. And yes, the PDPAL project, it's still an ongoing project. We have 12 months ahead before the end, but we decided to start this project focusing on Parkinson as probably one of the, let's say, scenario in which palliative care probably needs to be improved and spread in terms that PD patients have a considerable mounting unmet physical and social and spiritual needs that need to be addressed somehow. And we have different barriers and challenges that we would like to face, and specifically to face the problem of the that palliative care is linguistically challenging, and probably we'll have a discussion about this with our speaker today. Our ambition is to overall validate a new model of palliative care that now probably needs to be a little bit more integrated into current care and management of Parkinson's disease, especially in the late stage, by involving not only healthcare professional, but also caregiver and of course patient. And our mission now is also to pursue also educational pathway to involve more and more students from the healthcare professional to be familiar with this concept that we believe should be a pillar in the care pathway of Parkinson's disease patient. The PDPAL consortium is composed by 10 partners from 7 different European countries. Our project was joined also by the Skane, Region Skane University Hospital of Lund, who has joined our PDPAL clinical trial, which is ongoing. And we have lots of partners joining our project, like the European Association of Parkinson's Disease, and also other projects like EAPC, who are funded from the European Commission and try to improve the care pathways for Parkinson's disease patients. Our objective is to go through the the improvement and of palliative care for Parkinson's disease go through different pathways. One of them is the development of guidelines and recommendation of course, for clinicians to understand better when palliative care should be addressed. And we are doing also a clinical study to assess the importance and the efficacy of delivering community care through a nurse-based intervention, which is aimed at better taking care of symptom control in everyday life, but also allow patient and their caregiver to think about the disease trajectories and their course, and also express their wills. As I said before, we have also an important activity which concerns the educational part, and we have just started with the pilot phase of our massive online open course, which is available at our website. If you go on pdpal.eu/MOOC, you will find also all the information, and you are all invited to take part to this preliminary phase of the course, which will be finally launched in the second part of 2022. So thanks again to all the consortium and all the partners who are in the consortium of PDPAL project, and thanks again to the European Commission, of course, and the PDA who are supporting us. And again, thanks to the speaker of today. I will leave the stage to them, and I hope you will enjoy this webinar. The recording, of course, will be available through our channels after the webinar.
So thank you, Giovanni, for introducing us. I'm trying to share my slides. I hope it works. Okay. Can you just nod, David and Piret, if you see the slides? Okay, thank you very much. I'm trying to put it in full screen mode, in presentation mode. Let's see if it works. Okay, I'm almost there. Thank you. Sorry, but okay. Okay, is that working? Yeah. Okay. So no,
nothing's come up. We've lost.
Oh, I'm sorry. I'm trying again. And now?
We're in business.
Okay, thank you very much. Sorry for that. So I'm Simone Veronese. I'm a palliative care physician. I'm not a neurologist, but I have a lot of interest in palliative care, and above all in palliative care with neurological patients. And I'm also a member of the Italian Society for Palliative Care, and I work as a physician and a researcher in Faro Foundation in Turin, Italy. And today I will talk to you about the main principle and concepts of palliative care, so of general palliative care. And then David will talk about the role of palliative care in neurology and neurological patients. So first off, what does the World Health Organization say about palliative care? Palliative care is a crucial part of integrated people-centered health services. So palliative care is not accessory care, it's a crucial part of care, and is also a global ethical responsibility. So the mandate that WHO gives to palliative care is very high, very demanding. And it doesn't depend on the disease that you have, because as Giovanni said before, often palliative care is related to cancer, which it started like that. But as we will see, palliative care is for all people with severe suffering, okay? And palliative care so may be needed and has to be available at all levels of care. So this is what the WHO says about palliative care. And it also says that globally, only 14% of patients who need palliative care receive it. So can you imagine how many people with palliative care needs do not receive a crucial service? It's really important that. And 78 adults in need of palliative care live in low and middle income countries where services are underdeveloped, and of course they have more needs than probably we see in our populations. So overall, 40 million people are in need of palliative care each year. So the numbers are striking. The EAPC, which is the European Association for Palliative Care, probably the main association we have, because you know that modern palliative care started in Europe, so it's probably the more representative as an association, define palliative care as the active, total care of patients whose disease is not responsive to curative treatment. So here there is not the word cancer, okay? It's for patients whose disease is not responsive to curative treatment. And palliative care takes an holistic approach, addressing physical, psychosocial, spiritual care, including the treatment of pain and other symptoms. Palliative care is interdisciplinary. Palliative care can be delivered only by a team. So we can do it together as a group, as a network of care. So no one can be able by himself or herself to provide good palliative care. We need to work together to collaborate. And palliative care, in terms of principles, affirms life and regards dying as a normal process. Okay, so even if we talk a lot about end of life care, terminal care, and this can be associated with death, we are taking care of people who are very alive. And that's very important, because palliative care really affirms life and trying to achieve the best possible quality of life. This is the outcome of palliative care. So if you want to measure if palliative care is effective, you need to measure the impact it has on quality of life. And what is quality of life is what everyone says it is, but has important components that we saw before: physical suffering, psychosocial, spiritual issues. So all that is altogether can be palliative care, and quality of life. And the International Association for Hospice and Palliative Care, which is another, of course, big organization, set some principles as well. For example, communication. What is palliative care? Palliative care is, a lot of palliative care is communication, setting common goals, achievable ones. What can we reach together? Where can we go? Where would you like to go? What can we do to help you in achieving those goals? And of course, treating symptoms, emotional care, social issues, spiritual and existential issues, which are part of what you can do. But not only that, because there's also grief and bereavement for carers who are grieving for their dying patients, or the patients who are so disabled, who are feeling so unwell. And when they die, what happened after? So do we look at the carers who maybe were emotionally and physically distressed for their role of caregiving, and they are at higher risk of developing a bad period after the death of their loved one, so a pathological bereavement that can cause them to get ill and maybe to die. There are studies explaining that in the 6 months after the death of their loved one, caregivers are at a high risk of developing illnesses and to die because of that. So there are relatives. And then we also have to look at the team, our team, because we are dealing with very sensitive issues. Many people die, and that can affect the way we live, the way we are. And if we get ill, if we get burned out, then we will not be able to help others. So we need to look at our teams. I think this is a principle that should be available everywhere, but in particular, it's particularly important. Then there are ethical issues, and I know you will have some specific lectures on ethical issues, so I'm not staying on that, but can you imagine how many things can happen at the end of life in terms of choices, in terms of rights, in terms of what one wants and can or cannot receive, and so on. There are emergency legal requirements who are different in different countries, and they are evolving over time. So palliative care has to stay in that, in that environment, in that framework. So let's talk about how palliative care works. There are at least 3 levels of palliative care. The first 2, palliative care approach and general palliative care, are considered non-specialist palliative care. What is palliative care approach? It's an approach of care that should be part of all health carers' attitude and behavior. Because even if you're a neurosurgeon and maybe you're focused on in taking out a brain tumor, you need to have a palliative care approach for your patient, whatever will happen in the future. So everyone who has this task of caring for other people should have a palliative care approach. But general palliative care is what usually general practitioners, district nurses, and also specialists who are involved in the care of people who will die as a consequence of their disease should do. And above all, it is that palliative care which refers to people with mild to moderate palliative care needs. Because when things get hard and those needs become very high in terms of intensity, think about physical symptoms, psychological, and all those issues, That's where specialist palliative care should kick in. Because what we do as specialist palliative care professionals is just dealing with people with severe palliative care needs. That's what we do. So that's specialist palliative care. But we are only the tip of the iceberg, because most of the patients with palliative care needs are not seen by specialist palliative care services, okay, but are seen by other health professionals or people providing general palliative care. This must be very clear. And so we tend to say that people need to go to specialist palliative care when they have high palliative care needs in terms of number and in terms of intensity of that, okay? What are the settings of palliative care? Well, usually it says everywhere a person is suffering, they need to receive palliative care. This is what the WHO says. But there are specific settings. For example, the hospice. The hospice is a typical palliative care setting. That's where modern palliative care started at St. Christopher Hospice. You can see the picture here. I will talk about that in a minute. So those are places where people with severe suffering are admitted to be treated for their suffering, and hopefully then to be discharged, and maybe they can continue their life, or they can die there if they are in the end of life phase. But also home care. So most people die at home, above all in low and middle income countries. But that's where people normally should die, because home is the place where we live and the place where we normally should die. And we need to be cared at home if we want that. It's the best preferred place of death and of care of people. And so we need to reinforce home care services and also palliative care service to provide good palliative care to people who are cared for at home. But palliative care can be provided in outpatient clinics, in ambulatory, so people who are able to walk and to go there and maybe to have a consultation and maybe to start discussing about what will happen in the future. So plan their future care in these settings. So that's where palliative care can also play a big role. And then we have a hospital palliative care team. So specialist palliative care units working in the hospital for people who are there and they have significant palliative care needs, and many of them will die there. So they need to be cared of very well, even in hospitals, of course. And that's another place where sometimes you design the future. So when people will be discharged, where will be their discharge? At home, in a hospice, in a nursing home, because they will continue their lives there, and they need to be very well cared in the other. And maybe that can start in a hospital. And we also have care homes where many people die, and we know it in the future. A lot of people will die there, will live and die there, because care homes are homes. And so people who are living there have the same right to receive good palliative care based on their needs than all the other population, of course. So these are, let's say, the settings of palliative care. So what is palliative care and end-of-life care? Well, palliative care is not only end-of-life or terminal care, because palliative care is the care of the people who are severely suffering, and people can suffer throughout the trajectory of a disease. Let's think about Parkinson's disease. Maybe you can live 1 or 2 decades with that disease, and during all the time, you can have a lot of moments where you may need palliative care for issues like communication, we said, like planning the future care, like, for example, focusing on difficult symptoms or psychosocial issues or spiritual issues. And all that is very important during the trajectory of the disease. Because if we want to focus on end of life, and we know that end of life is very important, if we don't start earlier, how can we get there? In a person who suffered for 15 years, how can we be there in the last weeks? We will certainly lose that person. But if we know them, it will be very easy to be referred. The patient will be referred to palliative care, for example. And then we need to look at what happened after that for the relatives, as I said before. And there are specific pathways for end-of-life care. These are generic pathways, but remember some important steps. For example, the first one, discussion as end-of-life approach. When does end-of-life start? No one knows. It depends on you, the way you think about the discussion about end-of-life is what allows you to start a planning of end of life. If you don't discuss that, if you don't communicate, it will happen and you will not be prepared, and the patient will suffer at the end of life. And then the assessment of the needs. You need to be very precise. You know, we had a very good definition of palliative care. It says that palliative care try to reach the best quality of life possible for patients using an impeccable assessment of needs and treatment. So impeccable is not reachable, but it tells you where we want to go. We need to be very precise in assessing all the suffering, physical, psychological, etc., etc. And then coordination of care, because people don't have time. They don't have to. They cannot lose time to run after all the services they need. So there needs someone coordinating the services. The services that we provide have to be of high quality. We have to demonstrate that we can reach the outcomes. If we cannot reach the outcome of quality of life, or symptom control, etc., well, we cannot justify our existence. But it would be like an intensive care unit not able to show that they improve survival. What's the point? That's their main outcome. Our main outcome is quality of life, and we have to be so high quality to show that we can reach that, and then we will talk about that later. And the care in the last day of life and breathing, we have already said that, and all the other aspects of care. Who is Dame Cicely Sonder? She is recognized as being the founder of the hospice movement, so of the modern palliative care. And one interesting thing is that when in the 60s of the last millennium, she opened the St. Christopher Hospice in Southeast London. In some letters, she stated that in the first year of activity, main patients, of course, were cancer patients, but some patients had ALS and Parkinson's disease. So the relationship between palliative care and neurology started at the beginning of modern palliative care, and we are very happy of that. So talking about principle and concept, what did Cicely Sonder say, among all the other things that said, because she was very inspiring? She said that you matter because you are you, talking to a patient, thinking about a patient, and you matter to the end of your life. And we palliative care, we will do all we can, not only to help you to die peacefully, which is an important outcome, but also to live until you die. So that's affirming life. Even if you're dying, you're alive. And what we want to do is improve your quality of life, affirming the fact that you're alive. Okay. That's why palliative care is not euthanasia. Okay. Because we really think that life is important until the last breath, and our task is to make it as good as possible. Okay, and that's what Cicely Saunders asked us to do, and what we think we still have to take on today. And she also introduced the concept of total pain. So when a patient is dying, when a patient is really has a severe stage of a disease like Parkinson, for example, they have many aspects of suffering. So there is the physical part, so symptoms and comorbidities, the role of treatments that can sometimes even worsen the physical condition, but there is a psychological bit of suffering, so fear of suffering, pain, anxiety, depression, feeling a burden for others. And there are social issues, isolation, the loss of job, the loss of role inside a family. I was the one who took decision. Now I'm in bed. Who takes decision on my behalf? So that, everything is changing, but that's important because that's a cause of suffering, financial concern, dependency, and the spiritual issue. We are also spiritual. So what's the meaning of what's happening? Why that disease? Why to me? I have never smoked a cigarette and now I have a cancer. Why me? Why not my neighbor who is living so badly and I am in? What's the meaning of that? That's an important cause of suffering. But we also may have regrets, things that have not been solved, and we can help in solving that and leaving people, to die peacefully because they don't live with those regrets. Or sometimes faith can be helpful, but sometimes cannot be helpful at all. Maybe, sometimes faith is related to superstition. If I don't get the miracle, so why do I have the faith? These are important issues that we have to face in palliative care. Fear of the unknown, what will happen after? And a lot of time, these questions are not asked to the chaplain. They are asked maybe to the physician or to the nurse. What do you think about will be after? And you say, well, I'm here for the physical bit, but no, I'm here as a human and I need to be involved and tell you maybe what I feel about that. So, that's palliative care. And unfortunately, as Giovanni showed in one of his slides, there is a high disparity in who is receiving palliative care. If you have cancer, you have a higher probability to have good palliative care. If you don't have cancer, you have very less possibility. But unfortunately, most people do not die of cancer. They die of other chronic disorders. So that gap has to be filled. For example, if we look at this paper, they say that if you have a cancer, you have, for example, 75% of possibility to be in a palliative care register. What is a palliative care register? It's just a register that GPs tend to have, for example, in the UK, where when they sign in patients that they think they might die in the next 6 to 12 months. And what happens that just because you write that there, your attitude with that patient will be different. You will start communicating differently. You will ask different tests. You will change the way you will take care of them just because you have decided that. So 75 people receive that, and 70% receive specialist palliative care because they have very high needs. But if we go to people with organ failure, you see 80% do never appear in a palliative care register. They will never be recognized as in need of palliative care, and only 10% of them will receive specialist palliative care, even though many of them have very high symptom burden. For example, there are studies showing that if you have COPD, you have worse symptoms than if you have a lung cancer in terms of dyspnea, for example, but you don't get palliative care and you really need it. So that's absolutely unfair. And if you have dementia, it's even worse. Only 5% die of dementia. We know that dementia is a condition who is growing and people who are suffering, but it's very hard to detect. It is possible to detect suffering dementia. But if we don't use the right tools, if we are not proactive in looking after that, we will lose that suffering and people will die badly. And only 5% of people with dementia receive palliative care. So this disparity is a gap we need to fill. And we have tools that can help us. For example, this is a free tool that was published in the UK, saying that when you think about palliative care, for example, from a GP perspective, but even from a neurology perspective, you need to know that you have, first thing you have to do is to identify the people, the population you are looking after that might have palliative care needs. So this process of identification is very important. And it has, you see an algorithm here on the right saying, ask you the surprise question. What is a surprise question? Would I be surprised if the person I'm looking now were to die in the next what, 6 months, 1 year? It depends on, due to the condition, the main condition he has, or the comorbidities, the situation he's living in. Because if I'm not surprised, will I change something in the attitude of care with this patient? Will I start talking differently to him? And then, do they have indicators, general indicators of decline that tells you, well, I wouldn't be surprised, and he's weighing loss, he's eating less, he's moving less, probably he's really dying. And do they have specific clinical indication for that condition that can be related to Parkinson, cancer, ALS, COPD, whatever you want? So that helps you to identify the patients. And then you have to assess their needs and plan their care. And these tools are available and are quite easy to use. So I really suggest you to think about that. And there are principles of symptom management. We need to be proactive in the evaluation, so the assessment of patient, explaining what we think it can help, so how we think we can provide good care to the patient, and then manage that care and monitor and reassess the patient. Just an example to finish my presentation. Let's think about pain. Pain is a very common symptom in palliative care. How do we manage pain? First of all, we are proactive in assessing patients. We know that if a person has cancer, there are high probabilities he has severe pain, and maybe he is also thinking that he can have pain. So it would be easier to assess. But if this person has a Parkinson's disease or an ALS or dementia, is it the same? Maybe they can have the same risk of having pain, but we are less keen on understanding that. If we don't proactively ask them and use the correct tool to assess pain, it is possible. And then we can use non-pharmacological strategies. We have to prescribe when we have diagnosed a chronic pain. We need to give chronic drugs. We don't have just when you're in pain, take the drug. No, because chronic pain is a disease. So we need to use ATC, so around the clock medication, in order to cover that pain. And also always provide PNR prescriptions, because even if your pain is very well assessed and covered, maybe you can have breakthrough pains episodes, and you need to have something that will act very quickly and cover that pain. consider side effects. If I, for example, prescribe an opioids, then I need to think about laxatives, or because of course there will be constipation or maybe nausea. So all these things have to be considered. And the WHO letter for treating cancer pain and chronic pain is very helpful in determining which drug, depending on the intensity of pain and the role of adjuvants and so on. And then never forget to monitor and reassess the patient. So I'm finished. I thank you very much for your attention, and I'm very happy to let the next presentation to David for continuing our talk. Thank you very much.
Thank you very much, Simona, for this very nice introduction to palliative care principles and looking at it more broadly. And you and David are really the voices of neuropalliative care also within the European palliative care community, also for a very long time already. And that's why it's really great that also David is here, and now he will introduce us then with the neurological challenges maybe in palliative care. And I encourage you already write your questions into the questions and answers box so that we can have a lively discussion later, but of course listen also carefully. So thank you very much, Simone, and welcome, David, and floor is yours.
Thank you very much. I'm assuming everyone can hear me all right. Yes. Thank you. I'm a retired consultant in palliative medicine. I worked in a hospice in Kent for 30 years, over 30 years. I'm still now an honorary professor at the University of Kent. And I've also been very pleased to be involved in the development of neurological palliative care. And one of our studies that we undertook 5 years ago now is with the EAPC, of which I'm chair of the group on palliative care, and the European Academy of Neurology. We did a consensus document. I put the reference at the end. But within that, we said very clearly, in neurological disease, palliative care should be considered early in the disease trajectory. But that would depend on the underlying diagnosis. So as Simona has said, we're looking at the physical aspects, and that is symptom. There are the symptoms. I'm not going to go into that, but there's also the issues of positioning, of mobility, of communication with neurological patients, patients who may not be able to communicate because of their disease affecting their mouth and their speech system, or it may be because of cognitive change or of dysphasia with brain tumor. But there's also psychological, emotional, and spiritual. And I'd like to just take a few moments looking at how that may be for neurological patients. I think someone with a neurological disease often has multiple losses to cope with. They're physical losses of mobility, of speech, of swallowing, maybe even of breathing, of cognitive changes, as you all know, of emotional issues, of how do you express your emotions? How do you tell your wife you love her when you can't speak? Or that every time you think of talking about how you're feeling, you burst into tears or start laughing because you have emotional ability. I think patients have fears of the disease, of fears of death and dying. And they may be more in neurological disease than other diseases in many ways. Certainly in the UK, whenever there is discussion about assisted dying, people with ALS or Huntington's talk about their fears of dying a very distressing death. Now we know from the literature and from experience that with good palliative care, the fear of a distressing death is no greater than with any other disease group. But it's there in the newspapers, in the discussions. Within families, Simone said about the changes in role, the person who's been in charge doing things no longer is able to do those things. Of the losses, the patient, they can't communicate anymore, or within a partnership. And within palliative care, we're often very good at talking about death and dying, but maybe less able to talk about intimacy and sexuality. but within these the neurological patients may want to talk about those losses, their fears of the disease, their financial aspects, because they're looking at long-term care, their emotional changes and their fears about death and dying. And Simone has talked about the spiritual aspects. It isn't necessarily religious. It's more the deeper meaning of life, the why me, the existential distress, the fears of dying and the fears of death. And I think there's, as he was saying, it's a role of all of us as professionals to listen. And there may be spiritual support needed from a spiritual religious leader or a counsellor. I've put the reference to Gofton, which is a very good paper on how palliative care may differ in these psychosocial issues and spiritual issues. So within our consensus document, we talked about palliative care being involved earlier, and that end-of-life care might be discussed as a continued and repeated discussion, particularly thinking because things are going to change. We need to encourage that open discussion about the dying process. And we need to open discussion about the wish for hastened death. In the majority of countries, we will not be able to do anything, but people will still want to be talking about, I wish this was over. And we can talk and find out what is there behind that fear, that wish. Is it the fear of the future? Is it the fear of what's happening, of being a burden, which we may be able to help? But just listening and hearing that may be important. And we need to recognize that deterioration over the weeks and months so that we have a diagnosis that allows us to intervene appropriately. Do we need to start thinking of whether someone's intervention, perhaps someone with ALS who is receiving non-invasive ventilation, do they still wish to receive that? Are there medications we can change? I still remember seeing so many patients who are having their statins to stop them having a heart attack in 10 years' time when they were going to be dying in the next few weeks or months. Are we supporting carers and families at this time? Are we looking at care pathways to help us with that? And I think the carer support is so important for people with neurological disease. The carers before and after the death. I think after a death, so many close family members have a sense of relief. Oh, I'm so pleased. And then think, because I'm not having that burden, but then feeling very guilty that that they're having those feelings. And I think professionals need to be thinking about how to cope with emotional exhaustion and burnout by the education, by support, and by supervision. It's something we have to be aware of. When might we be thinking of end-of-life care? This was, again, a consensus group of ideas that came out of a program in the UK over 10 years ago. Perhaps when patients and families are requesting to talk about end-of-life care, realizing, is it with dysphagia, cognitive decline, breathlessness, repeated infections, particularly lung infection and aspiration pneumonia? Is it weight loss, or is it that gut feeling we may have as a clinician that this person is just deteriorating? And we looked at that in a big group of people, and we found that on the left is time of death, on the right is 24 months before death. And as you can see, the number of those triggers increase, particularly from about 6 to 5 months on, they go up appreciably. But you may see that that red area, which is aspiration pneumonia, becomes commoner and commoner, and that purple area becomes commoner and commoner as you get near to the end of life. And if someone has had an aspiration pneumonia, and particularly repeated aspiration pneumonia, there is a high likelihood they are in their last 3 to 6 months of life. And Simone's talked about this variable input of palliative care. Perhaps if we look at someone with ALS, it may be a diagnosis when they're very fearful, when they're having swallowing problems and need to think about a gastrostomy, when they're having breathing problems, when they're actually in the last few weeks and months of life. But with someone with Parkinson's, this may be over many years. With ALS, it may be over 2 or 3 years. With Parkinson's, it may be over 10, 15 years, but there will be particular issues. And how do we find out what those issues are? Perhaps by regular assessment using IPOS or one of the carer assessment systems. Is neurological palliative care effective? I think we need to say this, and for the future, we need to have more and more evidence. This was, Simone and I were involved in a study several years ago where it was a waiting list approach where some patients had the palliative care team initially, others waited for a period of 3 to 4 months. And we found that quality of life, symptoms improved in the group that have the palliative care team involvement. But interestingly, the death rate was similar in both groups. And that was as important to be able to tell people that actually having a palliative care team didn't mean that you died quicker. In the USA, there's an integrated clinic of neurologists, social worker, chaplain, and nurse, again showed quality of life improved. And there was improvement in non-motor symptom burden. This was for people with Parkinson's disease, that their motor symptoms were less severe. The caregiver anxiety and burden were reduced, and people increasingly completed advanced directives and advanced care plans. And then in the UK recently, there's just been the OpCare Neuro, which was a short-term integrated palliative care approach, and looked at a large number of patients. Unfortunately, there wasn't clinical significance on key symptoms, but again, there wasn't an adverse survival. There was evidence of reduced costs in both groups, but qualitative studies showed that the group of patients who had had the integrated palliative care team had talked about their resilience being built up, that they had felt that their deficits and the functional issues that they really were worried about had been attended to, and the carers felt enabled to care. So there we have to look at how we find this effectiveness. And I think we're talking about collaboration so often. Neurology services will provide palliative care. The team may know the patient and family over a long period of time. They have expertise in management of symptoms. But perhaps there is that close liaison and collaboration with specialist palliative care for complex issues, whether that's physical, psychosocial, or spiritual, or ethical issues. Perhaps thinking of ALS, the withdrawal of ventilation, but with other diseases, other disease groups, are there interventions that we withhold or withdraw? And that collaboration may be that the multidisciplinary team includes palliative care. You know, more and more there is an increasing use of the neurological multidisciplinary team, that a member of that team has experience in palliative care, or their specialist palliative care team member comes in, or there's increasing liaison. And there is, particularly in the USA, this development of a neuropalliative care team. It's a neurologist who has palliative care experience and expertise. And that may be combined in a wider group of care of neurodegenerative disease, looking at a wide group of issues. And perhaps this, we talked of the 3 layers, that there may be the primary palliative care at the bottom, the generalist team providing a lot of care, and then specialist palliative care working together and providing for those complex, whether that's symptom, family, or ethical issues. And we looked at this across Europe and found that actually collaboration, when we asked neurologists and palliative care specialists, was there collaboration? It was low for Parkinson's, for MSA and PSP, whereas with cerebral tumor and MND-ALS, it was very much higher. And actually, there was no collaboration for large percentages of, particularly with the Parkinson's plus disorders. Were there barriers to that collaboration? Palliative care talked to reluctance to refer by neurologists. There were some financial issues, but interestingly, patient and family reluctance was unusual. 15% of palliative care specialists and only 10% of neurologists. The neurologist also said that there were problems of finding a palliative care service. In some countries that was very limited, or that service that was available didn't accept neurological patients. So that's a challenge both ways around. So I think we have a challenge. We have a challenge of recognizing the need for end-of-life and palliative care, and that's recognition by patients and families, although the studies have shown that may be less than we think, of professionals, of services, and we need to look at that, how we develop that collaboration with neurology and palliative care, but it also includes rehabilitation, the general medical care, primary care, and specialist palliative care. So it's quite a complex area. And I have put some references there so that you can look at those later. So thank you for listening. I hope that's given you an idea of palliative care, neurological palliative care, and I'm hoping there are lots of questions now in the question and answers and chat facilities. Thank you very much for involving me in this big project.
Thank you so much, David. And as long as people are we have now two options. So you either raise your hand, and then we will switch on your microphone and you can propose your question live. So this is an option. Or you type your question into the question and answer box and we will mediate it. You can even use your native language. I think we manage with the languages that are present here. So don't worry about that. Simona mentioned that language is always, it was Giovanni, that there are linguistic challenges within Europe. We don't have those in our project. So, I was just wondering, there is a literature review that indicates that people receive palliative care 18.6 days before their death. Now, if we think about people who suffer from neurological conditions, and when we think how palliative care is financed in many countries, do you see?
It's a real issue, because I've been pressing to say that palliative care, as Simona was saying, should be thought of for a disease like ALS at diagnosis or soon afterwards. For other neurological diseases, it may be much earlier when there's a problem. It should be on need, not on diagnosis or prognosis. But as you say, it can, in the USA, you can only have hospice care for 6 months, and you have to give up all other active treatments. And that means that people are very restricted. And, I think we need to get this thinking of what's going to happen in the future from earlier. If there are particular times at diagnosis, maybe time to discuss what's going to happen. When there are interventions, if someone is having a gastrostomy, having ventilation, in Parkinson's is deep brain stimulation being discussed. These are signs that someone is deteriorating and that we should be thinking, let's talk about what's going to happen next.
Yeah.
What's going to happen in the future now? This may be a year, 2 years, 3 years before the person may die. But let's talk about it now. And I think there's an imperative with many neurological diseases because we know people are going to lose their communication. You know, to talk about their fears of the future through a communication aid is really difficult. It's much easier face to face when you can talk. And we also know that many people are going to lose their cognition, or it's going to be difficult. So we need to talk about it much earlier. That may be when they don't want to, but we need to try and encourage them to think ahead. And I think I'm sure will come out when you talk about advanced care planning. It's we're thinking now, what's your thoughts for the next few months? Not necessarily how do you want to die, but how do you want to cope with this, with how you are over the next few weeks and months? If there are problems, how do we cope with that? So it's getting palliative care much earlier in the disease progression.
Yeah, thank you, David, for this raising all these issues that indeed are so relevant. You, Simone, mentioned this option of dying at home. And I know that there might be homes that are not necessarily suitable for dying, where people don't feel safe. So we have it also in one of our lessons. We discussed it, what it might mean. There are also people who are, for example, imprisoned, who are homeless. And in palliative care, we have this very strong message of that the home is the best place to die. Do you think that this is something also like a future challenge for us that we should think when we think about concepts that needs maybe some redefining?
Yeah, we have to think about a concept of home in general. But what I can tell you, for example, is that in the last EAPC conference, there was a very interesting presentation on what will happen in the future. And what will happen in the future will be that we are going to have a lot of people, all people with a lot of comorbidities, with a lot of problems, with a lot of palliative care needs. And the actual settings are not going to be able to help them. So we need to rethink home in terms of different settings where people are going to live. Hospitals will not be able to increase the number of deaths in their settings if they want to care for people who have some changes to survive. Hospices, we will never have enough hospices to allow people dying there. Homes, if someone have a home and can have an appropriate home care, literature says that, not palliative care, but the literature says that this is the preferred place where people would like to spend the end of their life, in general, whenever possible. When it is not possible, we have to imagine something different. And the first thing to do is to try to think where people is living now. And most of people will die in care homes. In different, care homes can have different level of care. There can be nursing homes, there can be general care homes where people just live together because they need to be help each other or have some professional helping them. But that's the place where they live. So that's where we need to help them in living. So it's not that it is not palliative care who wants to decide where people have to die, because this is not our role. Our role is to help them where it's better for them to decide that. But I would like to come back to the previous question, just to add a concept that one of the reasons why palliative care is involved so late, it is because it is, and this is where education kicks in. We also as professionals have in mind that palliative care is bad news. So when we involve palliative care, it's because things are going bad. On the other hand, we said we are improving quality of life. So we're not bad news. We want to be good news. And that's why we need to be involved as early as possible, because we need time to work. And we also need time to plan where people want to die. So when we think about advanced care planning, about advanced decision, it's not just where people want to die or how they want to die, but how they want to live. So what choices are going to be on the table. Can we stay at home? But if you want to stay at home, maybe we have to rethink about the home. Maybe we have to rethink the way we're providing care. Do you want to stay in a nursing home? Maybe we have to see if the nursing home staff is able to provide, for example, good symptom control. But you can do that if you start early and if you're not seen as the thing that comes just before the undertaker, because that's not what we are doing. You know, we're trying to be good news. That's what we want to do, and that's where I think education should play a role. I don't know if
And I think we've been very keen to say we need to have education for palliative care specialists in neurology, but we also need to try and work with neurologists to have their awareness of palliative care, because there was obviously in the survey was a real reluctance by some neurologists to talk about palliative care. And you know, we need to try and get that involvement earlier. And I think when you look at the studies that haven't shown as much as you would hope of effectiveness of palliative care, it's often been for a short period of time, period of 2 or 3 or 4 months, by outpatient clinics, by telephone calls with a few visits. And actually, maybe it needs to be over a period of 18 months so that people have the confidence to call someone in the middle of the night, that they have the confidence to say, my husband's not looking as good as he did, can you help me now? So that they have that trust and that build up that relationship. And I think home, everyone talks, if you ask people, about 70% will say they want to be at home. But if you wait a moment or two, and one study did that and say, a lot of people, about half of those people would say, as long as it's all right on my family. If my wife is in an awful state, put me in a shed at the bottom of the garden, get, you know, anywhere. I don't want to cause her problems. And I certainly don't want my children giving up their jobs and causing problems to my beloved grandchildren. I'll go anywhere. So there is this care at home is maybe ideal. But the other side of that is there are countries where they've looked very much at trying to have a community response. You know, in India, in Kerala, you know, palliative care is provided by many, many people in the community. So it's your neighbors, your friends, your other wider family, rather than it being left to just 1 or 2 people. And we may have to learn in our other societies, you know, where we don't actually know who our neighbors are, let alone ask them to help us. We might have some learning to do about how we work as a society.
Yeah, now this is a good message. I think that we have to look at the time, and it is Friday evening, you see now as we meet live. So I think that we have made a good start to this webinar sessions. I thank you very much again, and we will continue with these important questions. So the ones who participated, and there is even one question, but we couldn't come to it. But Simona, you will write the personal answer to Chiara about why Italian neurologists do not discuss the issue of palliative care, and we have pointed out some future challenges in this group, and we will continue doing so. And I think that there is also in the air something that is called professional loneliness. So maybe if we join our forces and work on this topic further on together, some things are going to change as well. So thank you very much, everybody. And thank you for our speakers. And Giovanni, you have the last word.
And yes, the next appointment, we would like to continue with delivering high quality content to all the followers of our project, or the people that join this adventure together to spread the voice about palliative care. The next talk will be next week, always on Friday at 5 p.m. CET. And it will be about late-stage Parkinson's disease management. So it's a more specific topic, but we hope that it will be of interest for most of you. So thank you once again to everybody, and let's be in touch. You will find all the information through our channel, website, and yeah, let's see next time. Have a nice evening. Bye.
Bye.
Bye bye. Bye bye. Thank you for organizing this.
Yes.